sex span, which I've never heard before. What is that?
Sex span is how long you are able to engage in satisfying sexual activity. And most men, most women want their sex span to last as long as their lifespan. And there's many things you can do to significantly prolong your sex span. And I call it the 4 pillars. So let's talk about sex.
Dr. Mohit Khera is a board-certified urologist and professor who specializes in male and female sexual dysfunction.
His groundbreaking research has significantly contributed to improving sexual health and fertility.
Millions of men and women are suffering from sexual problems like infertility and sexual dysfunction. For example, in the US, roughly 43 to 48% of women suffer from female sexual dysfunction, which involves 4 components that we're going to talk about. But we also know that premature ejaculation affects 30% of men globally. And also 40% of men at 40 will suffer from erectile dysfunction. And it's the first sign of other major adverse medical problems. For example, 66% have some degree of depression, and 15% of them will have a heart attack or stroke within 7 years. And if you look at the causes for ED, one of the biggest factors is obesity, which causes testosterone levels to go down. But men need testosterone for sexual function, so do women, because low testosterone increases low libido. But the issue is that people don't talk about their sexual problems. They suffer in silence and they start avoiding sex. But it's curable. And I have 2 ways to raise their testosterone, techniques to significantly improve the quality of your erections, and natural ways to improve sexual function in men and women. So number 1, most important is...
This has always blown my mind a little bit. 53% of you that listen to this show regularly haven't yet subscribed to this show. So could I ask you for a favor before we start? If you like the show and you like what we do here and you want to support us, the free, simple way that you can do just that is by hitting the subscribe button. And my commitment to you is if you do that, then I'll do everything in my power, me and my team, to make sure that this show is better for you every single week. We'll listen to your feedback, we'll find the guests that you want me to speak to, and we'll continue to do what we do. Thank you so much. Dr. Mohit Khera. Who are you and what have you spent your life doing?
So I'm a urologist, and I specialize in male and female sexual dysfunction, testosterone replacement therapy, and infertility. For the past 17 years, I've been working as a professor at Baylor College of Medicine in Houston, looking at ways to improve sexual health, improve testosterone, and improve fertility.
And we talked just before we started recording about this term sex span, which I've never heard before.
Yeah.
What is the sex span and why do you care about it?
Yeah, so Stephen, you know what lifespan is. It's how long you're gonna live, right? And you also know what health span is, how long you're gonna live in a healthy lifestyle. Mm-hmm. But you may not have heard of the concept of sex span. Sex span is the ability to engage in sexual activity, satisfying sexual activity. And so how long you are able to engage in sexual activity is important to most men, right? So let's give you an example. The average lifespan in the United States is 77 years old. The average health span in the United States, believe it or not, is 67 years old. In fact, if you look at the CDC and they talk about how long you'll live without a disability, it's actually 63. So there's a delta here. There's at least 10, 15 years where you will be in some kind of disability and cannot live to your fullest. Now think about the concept of sex span, how long you'll have the ability to engage in sexual activity, satisfying sexual activity. We, most men, most women, want their sex span and their health span to last as long as their lifespan.
Yes.
So I think it's important.
And there's things that I can do to make my sex span last as long as my lifespan.
There's many things you can do, and I call it the 4 pillars. The first is diet, exercise, sleep, and stress reduction. I don't have a pill on the planet stronger than diet, exercise, sleep, and stress reduction. And each one of those can significantly improve a man and a woman's sex span, but also their health span and their lifespan. The other is hormones. Testosterone, extremely important. Testosterone supplementation can significantly improve a man and a woman's sexual function. And unfortunately for women in the United States, we don't have very many options. Actually, globally, for women, there's not many options. But I think it's important, hormone replacement therapy. And one more thing, I think about the couple. Think about sex span as a couple's disease. Let me give you an example. Tomorrow, Stephen, are you married or?
Yeah, well, I'm in a long-term relationship.
Your partner. So let's say your partner tomorrow says to you, I am no longer gonna have sex with you. Unless you cheat on her or you leave her, you're not gonna have sex again, right? Think about the importance of the couple. So I talk about this quite often. Keep your partner engaged. Keep your partner healthy if you wanna prolong your sex span.
So I've got 2 questions here. The first of which is, who have you worked with in your career? And the second question is, what is your CV? Give me a rundown of your professional experience.
Yeah, so I started my residency in 2000, and I did my residencies in 2000, 1 year of general surgery. I did 5 years of urology training, and then I did 1 year of a fellowship in men's health. As soon as I finished my training, I joined the university at Baylor College of Medicine, and I started a basic science laboratory where we do basic science research in sexual medicine and testosterone for the past 17 years. And I just started a clinical trial, so I have a clinical arm where we do clinical research. I see approximately 150 patients a week, every week. I do approximately 6 to 8 surgeries every week. And I still work at the VA hospital. It's a veteran government hospital, 1/2 day a week, working with the veterans. So it's quite busy, but my passion really is education, research, and clinical care. And that's what we do. And so, when I started how I really got into this was when I finished my training, I was so proud of myself. I was able to get these men, these amazing erections, these great libidos. And I realized one day this woman called me and she was frantic. And she said, look, you're treating my husband. You're able to get him these great erections, great libido, but I don't want to have sex with him. And he wants to have sex with me all the time. And now we have a terrible relationship. You've ruined our relationship. And I thought to myself, wait a minute, this doesn't make sense. But she was right. In sexual medicine, either leave both libidos low or raise them both, but don't raise one or the other. It's a setup for disaster. So very quickly that year, I went out and flew out to meet with Dr. Irwin Goldstein, who's considered one of the godfathers of female sexual dysfunction. I spent some time with him, went to his courses, and for the past 16 years, I've been treating women as well. You can't just treat one patient without addressing the other. And so therefore, it's a couple's disease.
And give me a flavor of the types of conversations you have on day one when they walk into your practice, when they come to see you. What is the issue that they say they have and how do they express it? Like, what are the words that they use? And if you could just give me 5 of the most popular things people say to you when they come to see you.
So listen, first of all, men and women are very different how they express it, so we'll talk with men. Most men, let's backtrack. Most men and women do not get any kind of medical care when they see their primary GP. In fact, most GPs don't address sexual dysfunction. There was a study looking at medical students. Only 65% of US medical students get training in sexual medicine. And of those 65, 50% of those students said that the training was terrible. So we don't get the sexual medicine training to address the problem for patients. So the majority of patients are never discussed about their sexual problems. But when men come in, most of them are coming in because they already have tried some medications that haven't worked and they're looking for other solutions. Now, there's 2 simple questions you can ask a man. They're very straightforward. Are you able to get an erection sufficient for penetration? It's either yes or no. And are you able to maintain that erection till orgasm or pleasure? It's either yes or no. If he answers no to either one of those questions, he suffers from erectile dysfunction, right? And so it's very important to get a detailed history. You want to ask particularly, are you able to get an erection on your own? Are you able to get an erection with masturbation? Do you wake up with morning erections? If he says, look, doc, I get great morning erections, or with masturbation, I have great erections, then this has to be psychogenic, right? With my partner, I cannot get an erection, but when I'm by myself, everything works fine.
Psychogenic.
Psychogenic ED. It's a big component.
What is psychogenic?
Mainly something in the mind that's bothering you or inhibiting you from engaging in sexual activity. And that's where the sex therapist comes in, right? Because if someone tells you, I get great erections by myself, but with my partner, I'm not able to get good erections. Psychologically, when they're with their partner, they're not able to achieve a good erection. Sex for men and women has a huge psychogenic component, So I think it's very important to get detailed history. Are they able to get erection? What did they try? What medications have they tried? You have to query about depression. 66% of men who come in with ED have some degree of depression, 66%, right? And that's important. Anxiety, 35% is very important. And more importantly, we'll talk about this. ED is the first sign of other major adverse medical problems. For example, if a man comes into my office today, 15% of them will have a heart attack or a stroke within 7 years. 15%. The day they get ED, 15% will have a heart attack or a stroke within 7 years. It's the first sign. Other studies, Dr. Montorsi showed that if a man presents to the emergency room with a heart attack, on average, 39 months earlier, that's when the ED started. So it is the first sign. Now, there are many reasons for this. One theory is called the arterial diameter theory. The penile arteries are the smallest arteries, 1 to 2 millimeters. The coronary arteries are 3 to 4 millimeters. The carotid, 6 to 7 millimeters. So if you remember from physiology, if you're going to block an artery, 50% occlusion of an artery causes damage. So if you're going to block an artery, you're going to block the penile arteries before the coronary arteries. You're going to block the coronary arteries before you block the carotid, right? So men will get ED before they get a heart attack, more likely to get a heart attack before they get a stroke. That's a theory, but it makes sense. So I worry when a man comes into my office, could this man have occult cardiovascular disease? In fact, there was a wonderful study that came out of Greece. They looked at 50 men that walked in, and they gave them an echocardiogram or stress test. If it was positive, they went on to a coronary angiogram. What they found is that roughly 20% of men, 1 in 5, actually had some occlusion in their heart, whether it was 1 vessel, 2 vessel, or 3 vessel disease. So I think to myself every time I'm writing that prescription, is this one of the 5 that could have some occlusion? And is there an opportunity to intervene at this point? So it's really important to think about cardiovascular disease as well.
One of the big subjects that I hear a lot about, even in my friendship groups, is about libido. I've got so many stories in my friendship group of either one or both partners losing their libido. So on this subject matter of libido, it's kind of where I wanted to start this conversation. What is the most frequent and popular reason why men and women struggle with libido problems? And how much of that is about compatibility?
Yeah. Good question. Libido is multifactorial. There are many pieces of libido. It's very complex, and I'll give you some important components. First, it could be hormonal. And the mnemonic I teach the residents is PET. The 4 hormones that can affect someone's libido are prolactin, estrogen, thyroid, and testosterone. So you have to check the PET. If the prolactin's elevated, the libido goes down. If the testosterone's low, the libido goes down. So maybe it's a hormonal issue, which could be it. And particularly many women who go through menopause suffer from hormonal issues, and it could be a hormonal issue. The second is something called neurotransmitters. So in other words, serotonin, norepinephrine, dopamine. Dopamine goes up, libido goes up. Serotonin goes up, libido goes down. So these all regulate how someone's libido will function. So one of the biggest culprits for low libido are antidepressants. What do antidepressants do? They increase serotonin and they decrease libido. So sometimes it's a medication or something that a patient's taking that will shut down their libido. For example, a medication that men take for urinary function called finasteride shuts down their libido. So there are certain things that you have to look at. The other components are lifestyle. Diet, exercise, sleep, and stress reduction, particularly fatigue and stress. If a woman is tired and she's exhausted and she has to choose between sex and sleeping at night, many times she may choose sleep.
Me as well.
Right, I'm just saying.
Yeah.
So fatigue is important.
Yeah.
Stress, and there's this cliche, this mnemonic, this saying that with stress is kind of interesting. Typically, if a man has a very stressful day, he will want to have sex to relieve his stress. Women have to relieve their stress to engage in sexual activity. It's kind of the opposite. You know what I mean? So I tell men, if you really want to have sex with your wife, do the dishes, take out the trash, do everything you can to tuck the kids in bed early, relieve her stress, because that will significantly increase her desire to engage in sexual activity. But the other one is psychogenic. So, we talked about that earlier. Sex has a huge mental component, your relationship with your partner, how close you feel with your partner. So sometimes patients come to me and they're in an abusive relationship and they say, give me the pill that improves my libido. I say, it's not gonna work. I mean, the essence, the core, the foundation is not working. And therefore, it's really important for them to see a sex therapist. One thing for men that actually shuts down their libido is when they start developing erectile dysfunction. So if a man starts getting erectile dysfunction, let's say he gets a good erection 50% of the time, and he's starting to have some problems, and it's 10 o'clock at night, and he says, look, I can try to engage in sexual activity, but it may or not work, and it may be frustrating and embarrassing, or I can just go to sleep. He's probably just gonna go to sleep, right? And it becomes a vicious cycle because the less sex he has, the more difficult it is to engage in sexual activity later on. And so you may interpret this as a low libido, but he's really just avoiding it because he doesn't want to deal with it, right? But the partner also looks at this as maybe I'm not attractive anymore. Maybe there's something about me that's not appealing, and it becomes a vicious cycle. So one thing you can do is significantly improve the quality of the erections in a man, and that actually helps improve his libido. So for example, if I tell a man, if every night you have a great erection, and every morning you wake up with a great erection, what are you gonna probably do? Probably gonna use it, right? So libido inherently goes up, right? So I think ED and libido are tied very closely.
How do you define the term libido in simple
It's a
terms?
desire to engage in sexual activity, right,
Okay.
for men and women. And you have to, when it's a true problem, they have to be bothered by the condition. So I just want to be very clear. There are women who have low libido and say, I really don't care. I'm happy that I have a low libido. Well, then it's not an issue, right? You have to be bothered by the issue.
So on this psychogenic element where it becomes a vicious cycle, I've seen this in my own life several times, well, at least once. And I've seen it in some of my friends where, because there's a bedroom issue, when you go to the bedroom, you're both a little bit anxious, and then one of you can't perform. And if you can't perform, it exacerbates the issue. And it creates this sort of vicious downward spiral of like, it makes the bedroom like a really awkward place to be. And this is how I think about when you're talking about psychogenic component. So in the case of erectile dysfunction, if you're thinking as a man, God, if I go to the bedroom, I'm not going to be able to get it hard. I'm not going to keep it up. It's going to be embarrassing. She's then going to ask me questions. She's going to think I'm not into her, which just makes it even harder. Because as a man, like, I perform best when I'm really not thinking about it and I'm like not anxious and when I'm stress free.
Right.
And it seems to me that the like antithesis, the opposite of great sex is like overthinking.
You are 100% correct. And this is what happens. Let's say a man gets ED just one time, young man. He says, that was really odd. And what's wrong? You know what he does next time he has sex? As he's having sex, he says to himself, I hope I don't lose my erection. I hope I don't lose my erection. The second he says that to himself as he's having sex, he's gonna lose his erection, right? Because he's so worried that he's gonna lose the erection and not enjoying the experience. So now it's happened twice. So now he engages sexually the third time, and now he's even more freaked out because it's happened twice, and it happens again. We call this the vicious cycle, right? Because now sex has become an anxiety event, an anxiety-provoking event. And so you really have to work on decreasing that anxiety and not thinking about it. That's where sex therapy comes in hand. And that's where a medication called daily Cialis has become unbelievably helpful for my young patients. Because daily Cialis is a medication that men take daily. You've heard of Cialis, right?
It's like the Viagra.
Yeah, it's like Viagra, right? So there's Viagra, there's Cialis, Levitra, there's Stendra. There's 4 different brands. But one of the 4 is meant to be given daily. It's a lower dose, 5 milligrams every day, and the larger dose is 20 milligrams. When you give a man Cialis, 5 milligrams every day, what it does is essentially is having that medication on board all the time. When he engages in sexual activity, he doesn't have to take a pill. He just has sex whenever he wants to. And I've found that to be unbelievably helpful in breaking psychogenic ED. Because now that's exactly what that is.
On the table.
Yeah, that's exactly what it is. Yeah, and so these are pills that are in the U.S. But what's nice is they used to be very expensive. Now if you look at Mark Cuban and a lot of the good RX companies, men can get 90 pills for $15 or $20, which is very cheap.
You use the word young men.
Yes.
Young men presumably shouldn't be taking pills.
They shouldn't, but what happens when they have psychogenic ED, because they think about it the most, is they need to break the cycle.
What's the cost? Because I'm going to be honest, I'm a pill skeptic.
Yes.
So I try and avoid taking pills to solve my problems.
Yes.
If I can.
Right.
Obviously, there's going to be situations where I can't.
Right.
And I accept that. But my bias is towards figuring out if there's another way before I take a pill.
Right.
Because everything in life comes with a cost, all things.
Yeah.
So there must be a cost to taking a pill to solve this problem.
Well, the actual monetary cost is unbelievably cheap.
Monetary cost is, I'm thinking about like, do I then get dependent on this?
Yes.
Do I have to take this for the rest of my life?
So there's no dependency. Let me tell you why I think that drug is so important. That daily Cialis has one of the only things, in my opinion, that actually reverses erectile dysfunction. So let's backtrack. I'll give you an example. Let's say today you break your leg, okay? I have 2 options, Stephen. I can fix your leg, or I can give you Vicodin, a narcotic. And if I give you the Vicodin or the narcotic, you'll still be able to walk until the Vicodin no longer works, and we're in trouble. Viagra is Vicodin. It is not a cure for your erectile dysfunction. It's just masking the problem. Daily Cialis, in my opinion, is one of the few things that helps cure ED. If you look at studies and you look at a penile tissue and we biopsy the tissue and then you biopsy 3 months later on daily Cialis, it physically gets stronger. So let's say you go to the gym today and ask you to lift dumbbells. What's going to happen to your arm? It will hypertrophy. With daily Cialis, we see hypertrophy of the smooth muscle, meaning it gets physically stronger. So in my opinion, it's one of the best things to prevent ED in the future, help reverse the ED process. More importantly, daily Cialis protects the endothelium, and we have to spend some time talking about that. That is the lining of the blood vessels. It's the brains. And the lining of the blood vessels is very important because once that gets injured, you start getting clot or plaque, which will get a heart attack, a stroke, and erectile dysfunction. So it protects the lining of the blood vessels. 2 other indications. It's FDA approved to help a man urinate better, FDA approved. It's FDA approved to protect the heart in terms of something called pulmonary hypertension. So in my opinion, it's an excellent medication. Patients say, do I get dependent on it? I say, you do not get dependent on it. And I feel like you're better had you taken it than had you not. You take it for 3 months, you get strengthening of the penile tissue.
What happens if I stop taking it?
If you stop taking it, there's a wonderful study by Aversa, and what he showed was that those patients that stopped taking it after 3 months versus placebo still had benefit in terms of endothelial function protection and erectile function protection than those people that took placebo. So thinking about saying, hey, if I go to the gym and I work out for 3 months, what happens if I stop? I say, well, Stephen, you're better off had you gone to the gym for 3 months. That's my opinion.
What is the downside?
There's side effects. So every drug has side effects, right? But they're low with 5 milligrams. Back pain, stuffy nose, headache can occur in these, but it's quite small. But I do think that this is one of the medications that really can make an impact in men's health. Think about it. If I told you there's a medication that protects your heart, helps your prostate, and helps men with erections, and it's affordable, I think that most men would say, I'm in.
What are the big side effects that people report when they're on Cialis?
So on the larger dose, headache, stuffy nose, back pain is more common with Cialis and other medications, but it can be reported. Remember, you shouldn't take these medications if you're taking a nitrate because it can drop your blood pressure. But other than that, these are very commonly used medications throughout the world.
And they're not suitable for certain people that have certain cardiac disorders, I'm guessing?
Well, the way this was invented, the first one, Viagra, came out in 1998. Viagra was in the clinical trials designed to be a blood pressure medication, and accidentally men were getting erections in the trial. So these medications are, in my opinion, cardioprotective. A very famous physician named Dr. Kloner published an article recently showing that those men who took daily Cialis had a 13% reduction in cardiac events and a 25% reduction in mortality. It just came out because of the potential effects of protecting the endothelial lining of the blood vessels.
How does this work to solve for the sort of psychogenic component that we talked about, that vicious cycle people get into with, like, I'm guessing you're telling me that it increases your probability of having a good erection.
Right.
But this still isn't really working on a libido, is it?
Right. So let's say you started falling through the vicious cycle and you started having ED and it was 2 times, 3 times. And now I put you on this medication. And every time you have sex, you have the most amazing erection of your life. And 30 times, 40 times, 6 months go by. And you're having these amazing erections. You're relaxed and you're calm. Then I start going to every other day. You still get amazing erections. Then I go to once a week. You still get amazing erections. Then I stop. You still get amazing erections, right? I just need to show you that everything is perfect again. And that has a huge value.
What about for women?
This is the unfortunate part. We don't have a lot of treatment options for women. And if you look about it, if I want to give you an example, in 2015, if you and I went into the drugstore in the US, Walgreens, and said, give me all of the drugs to treat men for sexual dysfunction, they would put 30 drugs on the counter. These are all the wonderful treatments for men. In 2015, there was not a single FDA-approved drug to treat women for any sexual dysfunction. Very sad. In 2015, the first drug to treat women for female sexual dysfunction came out, and it was called Addy or flibanserin. And flibanserin basically is a drug that a woman takes every day and increases her desire for sex. That's it. That's the FDA indication. Increases her desire for sex. Several years later, the second drug for women came out. This was called Vyleesi or bremelanotide. Essentially, it's an injection that she takes 45 minutes prior to intercourse, and it increases her desire for sex. But again, we have only 2 drugs. The reason being is because the research, the funding that we have for female sexual dysfunction is far less than we have for male sexual dysfunction. And it's unfortunate because, as I mentioned earlier, this is a couple's disease. And so many times I have to use drugs that I use for men to help treat women. So I do use Viagra for women, but Viagra for women helps arousal. So let me explain. Female sexual dysfunction has 4 components. One is decreased libido. The second is decreased arousal. Third is orgasmic dysfunction. And the fourth is pain with intercourse. These are the 4. If a woman has any one of these 4 and she's bothered by it, she suffers from female sexual dysfunction. In the US, roughly 43 to 48% of women suffer from female sexual dysfunction, significant number. Only 19% seek therapy, will get therapy. So there's a huge number of women that I say are suffering in silence. They suffer from the condition, they don't know where to get help, and unfortunately, there are not many treatment options available, right? So it's a big problem and a big unmet need.
And on the hormonal component, you talked about how if dopamine is up, we're much more likely to be aroused. And if serotonin is up, then we're much less likely to be aroused.
That's correct.
So this kind of ties into something I was thinking when you were talking about stress and tiredness. When I'm stressed and tired, is my dopamine down?
It can be. Your cortisol goes up, right?
Okay.
Your cortisol goes up. So your ability to get excited will go down. Your fatigue goes up. So it makes it much more difficult. And there's more than just dopamine and serotonin. There's norepinephrine, there's melanocortin, there's many other neurosteroids. And it's really just what we call a plus-minus game. If I have more positives than negatives, I'm going to have desire, and I'm also going to have orgasm, right? That's important also. So if you give someone too much serotonin and it goes this way, not only does the libido go down, but it's difficult to achieve climax or an orgasm. So one of the ways I treat premature ejaculation is I give them an antidepressant because it delays the orgasm. So we have to be very careful on these neurotransmitters, how we use them. But if you talked about ADI, the drug I mentioned, all it does is it increases dopamine and norepinephrine, which increases libido. So they increase neurosteroids. Many women, particularly with the history of breast cancer, like this because they don't want to use testosterone or estrogen hormones. This is non-hormonal, right? It's just neurosteroids increasing the desire for sex.
Can I think about dopamine and serotonin as like as scales?
Yes.
Where if I put weight on one end, the other one goes up, and if I put weight on the other end, the other one goes up.
Yes, there is a very famous, Michael Perman came up with the tipping point, and it's basically a scale looking at the pluses and the minuses. And if you have more pluses than minuses, libido goes up, orgasmic function goes up. If you have more minuses, essentially your ability to orgasm and your libido will go down.
So if I want to be aroused and have a desire for sex and have good sex, then I want my dopamine levels to be high.
Dopamine high, oxytocin high, norepinephrine high, serotonin low.
What are the types of activities that make my dopamine high?
Exercise
Okay.
can be a really high dopamine. Other things increase dopamine as well, right? So gambling, there's certain things that are highs, like gambling, anything that gives you a high. Certain foods will cause a dopamine rush, but they're temporary, right? And so
that's a problem, right? Because if it goes up and then goes
back down, they crash. So you want your dopamine to go up in men and women. So we use medications like Wellbutrin. Have you heard of Wellbutrin? It's an antidepressant, but that antidepressant increases dopamine. So I use that to help men increase their libido, or women to increase their libido or sexual function. I use ADI in men and off-label in men and in women to increase dopamine.
I don't want to do drugs though.
Yes.
I don't want to take any pills.
So then I would say that I need you to exercise, and you do, but exercise is critical. I need you to sleep. I need you to reduce your stress, right? Those things will significantly improve your libido.
So what things then lower dopamine? Because I've spoken to a few like dopamine experts on the show before, and they talked to me about this sort of, Andrew Huberman was telling me that when you do an exercise, like let's say gambling or go on TikTok, your dopamine's going to go up, but then it's going to crash below the base point.
Yes.
And some of us live in this kind of dopamine roller coaster where we're doing these dopamine inducing activities, our dopamine goes up, it then crashes below.
Yes.
And when it gets low, we have cravings for dopamine inducing activities.
Yes.
So we go out and want to gamble or go on TikTok again or eat something. And then it goes up again, and then we kind of live in this kind of roller coaster of dopamine. One of the things that I was told by a dopamine expert on the show recently that does that as well, that links to some things I found in your work, is pornography.
Yes.
And when we talk about this psychogenic component, we talk about dopamine levels. How much is pornography causing this libido crisis?
Yeah. Pornography and ED and libido is somewhat controversial. There's some data to suggest that it does not cause an issue, and there's some data to suggest that it does. The first question I ask a patient, when I ask a man, I say, is your ED present with pornography also? So if he says, look, I have erectile dysfunction with my partner, and I have erectile dysfunction with pornography, that's very different than when he says, I have erectile dysfunction with my partner, and I have amazing erections with pornography, right? Because then I know that there's a psychogenic component as well. This is what I believe. I believe that when a man watches excessive amounts of pornography, what his expectation is becomes hair, and his reality becomes hair. And that delta causes them to have erectile dysfunction and low libido. They're not getting what they're expecting to get. So many times I question men when they come in, all men who come in for ED, I ask, how much pornography are you watching? In men who watch excessive pornography, if I ask them to stop watching pornography for a while, many will report improvements in their erectile function and libido. So again, I do think that pornography in excess can have a negative impact only because of your expectation and your reality. The delta can be an issue.
I'm reading some stats here from JAMA Network that says the percentage of men between 18 and 24 reporting no sexual activity in the past year increased from roughly 18% to roughly 30% in the space of what looks like just a few years. And similarly, the average number of times American adults engaged in sexual activity per year has decreased from 60 between 1989 and 1994 to 50, roughly 50, between 2010 and 2024. These shifts suggest a notable shift in sexual behavior over recent decades. Why do you think this is happening?
I think it's multifactorial. So I think one is, I think that ED and sexual dysfunction is on the rise. And if you look at the causes for ED, it's very simple. You look at obesity, diabetes, metabolic syndrome. It's a pandemic. It's an epidemic throughout. If you look at just diabetes from 1990 to 2022, 100%, from 7% to 14% of the population. 1 out of 8 people globally are obese. 1 out of 8 people. So these can make it very difficult as obesity and diabetes go on the rise. What happens? Testosterone levels go down, right? So testosterone levels go down. So the ability to engage in sexual activity, the desire to engage in sexual activity will be impaired by these conditions.
I've got some graphs here. Which show global obesity trends, global diabetes trends. I'll put them on the screen for anyone that's watching on video. Also, there's been an increase in pornography consumption from what I was able to tell from doing some research. A 2020 study by the University of Antwerp found that 40% of people aged 35 to 45 who watched 300 minutes of porn a week had erectile dysfunction. In a 2021 study by JAMA, Public Health and Surveillance, on 3,400 men between 18 and 35 years old, 20% of the participants suffered from erectile dysfunction, and researchers found that the greater the viewing frequency of pornography, the greater the development of this dysfunction.
Yeah. And that's 300 minutes is quite a bit of time a week. It's
5 hours. Minutes, 5 hours.
5 hours a week, right? So so that's quite a bit. Yeah, that's quite a bit.
How important do you think that is as a component to this sort of fracturing in relationships? We think about people having sex with each other less.
Yeah.
We're heading towards a world of like virtual reality and AI.
Yes.
What role do you think that's genuinely playing? And you must have private conversations with men that are really suffering with these things.
So I definitely think it's a role, and it plays a factor, but not as much as the epidemic of diabetes, obesity, metabolic syndrome. We are, as a population, becoming more and more unhealthy, right, as time goes on. And I look at it, again, as a pie. It's multifactorial, right? Most of us now our socialization is virtual. And so we are not engaging and going into seeing, everything is done virtually. And so I think that's an issue. And so I really believe that pornography is a component, but the decline in overall health is a major component. The decline in testosterone levels decade by decade is also another component as well.
It's pretty terrifying that young kids at the age of like 12, 13, 14, when they open their phones these days, will be exposed to sexually graphic images, whether they chose to seek them out or not.
Yes.
And I've always wondered what that's doing to a developing brain. You know, how it's adjusting your expectations, how it's creating some of those psychogenic factors that are making you less aroused. And it's difficult, right? It's difficult to go out and find a partner. You have to like put on the aftershave, shave, take care of yourself. You have to like risk rejection, spend some money, be interesting.
Right.
So it seems like if from a evolutionary perspective, if I was just trying to like get my nut off or like,
Yeah.
I don't know, ejaculate, I've got this really easy way now.
Yeah.
Like it's so easy.
Yes.
3 clicks on a computer, we're off to the races.
Yes.
Versus like all the effort and rejection and pain of trying to find an actual human being
Right.
to have sex with.
Right.
And then when I do approach number one, when I log onto some website and click a couple of times, I'm getting no headache. I'm getting whatever I want. I can order from an endless list of menus.
Right.
And I'm sure in the near future, I'll even be able to make my own.
Yes.
And in not so distant future, I'll have it in my house and it'll talk to me.
Yes. Yeah.
So I
But
just
it's
think,
a problem. And you think about it, it's making it more difficult for people to socialize, right? So in other words, now when patients or people engage in sexual activity, and they're usually having sex on the internet or with pornography, when you actually engage in sexual activity with another person, it can cause anxiety, right? You get anxious. It's not something that you're doing regularly. And so I think that it can become an issue.
I saw an article this week from an OnlyFans creator who posted that one customer of hers had given her $4 million this year.
Oh my God.
And you think about what it would take for you to spend $4 million on a parasocial relationship with an OnlyFans creator sending you explicit pictures. And I don't quite believe we fully understand what's around the corner.
I agree.
These stats, I think, are nothing compared to what's around the corner. And I don't know, I think about it a lot because when I read these stats about erectile dysfunction being on the rise, and I read that we're having sex less and less, and then I see this rise in these parasocial relationships, I go, fucking hell, I think we're just at the start of an exponential curve. Let's talk about obesity then.
Yeah.
Because these stats here are pretty shocking. This one shows the global obesity trends, which just shows them going straight up.
Yes.
Which is horrific. This one shows global diabetes trends, which is pretty much straight up as well.
Yes.
Has there been any studies done that show the link between being overweight and your probability of having low libido and some kind of sexual dysfunction issue?
Yes, numerous. And so let's start with this. So obesity, it's not surprising that diabetes is going up because as obesity goes up, it causes insulin resistance. So obesity and diabetes typically go hand in hand. The problem with obesity is the following. Obesity significantly drops testosterone levels. So fat cells contain something called aromatase. Aromatase eats up the testosterone and converts it into estrogen. So the more fat you have, the less testosterone you'll have because you'll convert it into estrogen. Fat cells also secrete something called cortisol and leptin, which shut down your own natural testosterone production. So as it's not surprising that decade by decade, as you see an increase in obesity, you see a decline in testosterone levels in men, because the testosterone levels will come down as people become more obese.
And low testosterone equals low libido.
Low testosterone increases low libido. The number one driver, or the number one hormone for libido in men and women is testosterone. It's a strong driver.
Men and women.
Men and women. And don't forget that testosterone is also really important in erectile function. Men need testosterone for sexual function, so do women, right? It's extremely important. So now I have a hormone that's going down, that's gonna make it more difficult to get an erection. I have a hormone that's going down, that's gonna decrease my libido, and it's mainly due to this obesity that's occurring, one of the biggest factors. So obesity. Obesity also, if you look at the risk factors for ED, obesity, diabetes, cardiovascular disease, these are all risk factors. And so as obesity goes up, erectile dysfunction goes up. And the number one condition is diabetes. Diabetics are 4 times more likely to have ED than any other population. 4 times. So I get worried when we see this obesity, diabetes pandemic going up because it's increasing only the erectile dysfunction. Stephen, if you look at the obesity, the group that's having the greatest rise in obesity is adolescent obesity, not adult obesity. The kids, younger and younger ages, are having, that age group has the greatest rise of obesity. So what does that turn into? The younger population are starting out at lower T levels, and it has an implication on fertility because you need testosterone to produce sperm. That's very important.
So if I just lose a little bit of weight, that'll have a big impact on my testosterone levels.
Let's talk about that. It's not a little bit. So the best study was at the European Male Aging Study, Fred Wu. And what he showed was this. It's a bi-directional relationship. If you lose 10% of your body weight, you can actually gain 85 nanogram per deciliter in serum testosterone. If you lose 15% of your body weight, you can actually gain 250 nanogram per deciliter in serum. So it's actually significant if you can lose, but it also goes the other way. You gain weight, you drop the T proportionally as well. The only issue is I can get the patients to lose the weight, but I can't get them to sustain it. Many times they gain it back, right? But if they can keep the weight off, it significantly increase the testosterone levels. The best data we've seen is in the bariatric surgery data. If I do bariatric surgery on a patient,
which is
to help them lose weight, you can shrink the stomach. We do surgery to help them lose weight. They lose quite a bit of weight. Their T levels go quite up, right? And so again, there is a strong correlation between weight and testosterone.
Have you got any examples of patients where you've given them testosterone treatment in some form? You've done something to increase their testosterone, and you've seen a remarkable reported difference in their sex life?
All the time. Yeah, so first let's backtrack. There's two ways to give a person testosterone. If I give a young man testosterone, remember, it causes infertility. So you would never give someone testosterone if they're planning to have children, right? That's very important, right? So I have two ways to raise their testosterone. I can give you medications to raise your natural testosterone. There's several. There's a pill called clomiphene citrate. There's HCG. I can use medications to raise your own natural testosterone, and they preserve your fertility. The second option is I can give you medications like testosterone. There's 7 of them, but they will shut your natural production down. Not only will they shut your natural testosterone production down, but they will shut down your sperm production. Now, if you've already had your kids, you're 60 years old, your testosterone level's already low in the first place, what are you preserving? Okay, it makes a lot of sense. And there's 7 ways to do it. My favorite way are the injectables and the oral testosterone. They are fantastic. Oral testosterone is quite interesting. You know, first of all, testosterone was invented in 1935. This is not a new drug, 1935. And oral testosterone initially was feared because it would actually cause liver toxicity and liver cancer. And it wasn't until the 1970s when they were able to make oral testosterone undecanoate. And what's nice about undecanoate, it bypasses the liver, no cancer, but it had to be taken 3 to 4 times a day. It was available in the UK as a drug called Andriol, all over the world, but not the US. The US, we did not get our first oral testosterone till 2019. And then 2022, we received 2 more. And now we have Tilando, Jatenzo, and Kysatrex is our oral. They're taken twice a day with a meal. What's nice about Kysatrex, it's actually available in the UK. So in the UK now, they can actually get Kysatrex as well. But oral testosterone, most patients don't mind taking a pill, and it seems very easy to do.
So should someone like me be taking testosterone?
If your levels are low,
Yeah.
and you're symptomatic, and I think that's very important. If a man comes in with low levels of testosterone and says, I feel great, I have no symptoms, I said, I'm not giving it to you. These are the symptoms: low energy,
Yeah.
low libido, erectile dysfunction, decreased muscle mass, increased fat deposition, poor sleep, and depression. These are some of the common symptoms you'll see. Most sensitive symptoms are the sexual symptoms: erectile dysfunction and low libido. So if he says, I have these symptoms and my levels are low, and I recheck it and confirm that it's low, that man is a candidate for testosterone therapy. But if he's young, hasn't had children yet, I'm gonna say, look, let's hold off on giving you testosterone and use medications to make you make testosterone. And if you don't wanna take medications, actually, there are many things you can do on lifestyle modification to raise your testosterone. We talked about weight loss as well. So let's live in this area here. You are too young to take testosterone now. But conversely, let's say a patient comes in and has every single sign and symptom of low testosterone, but his testosterone levels are normal. I'm not giving him testosterone because it could be something else. Maybe he's depressed. Maybe he has a low thyroid. Something else is going on. So you must have signs and symptoms and a low T level to be a candidate. And if you fit that, then you may benefit.
What about women?
So this is important. In 1935, when testosterone was invented, it wasn't many years later till they actually started using testosterone in women. And early reports of testosterone in women were actually quite remarkable. The earlier manuscripts describe improved quality of life, improved libido. And if you and I walked into the drugstore today and said, give me the testosterone for women, it does not exist. There is not a single FDA-approved testosterone for women in the United States, but we have well over a dozen for men.
Can you explain this to me, just because I want to make sure I'm
Yeah.
clear? Why would a woman take testosterone? Because when I think of testosterone, I think of men.
Yes. So women make more testosterone than any other hormone in their body. make more testosterone than any other hormone in their body, right? And when women have higher levels of testosterone, they tend to see a greater improvement in libido, muscle mass, bone mineral density, sense of well-being. Some have reported improvements in cognition. As the testosterone level goes down, we start seeing these symptoms, particularly low libido. If you give a woman back her testosterone, many of these women see a significant improvement in their libido. But the issue is that we don't have an FDA-approved product for testosterone in the United States. I think in the UK you call it off-license. We call it off-label. Now in the UK they did have one. They had a wonderful patch called Intrinsa. And then the women in the UK could get the patch for testosterone, go into the drugstore, NHS covered it, and it was fine. Then they had Androfem, and Androfem was actually approved and now no longer is approved. So now in the UK, you also don't have an on-license medication. You can still get Androfem from Australia, but unfortunately, it's very difficult to get. So what do? We use the drugs for men and we give it to the women in 1/10 the dose. That's all we do. So if we have a packet that a man puts on a day, we say use 1/10 of the packet every day for the women, and they can see significant improvements. It is not illegal to give a woman testosterone. It's just considered off-label or off-license. But they see significant improvements.
In what?
Sexual function by far the most. Libido goes up, no question. Many women report that. Muscle mass. If you think about testosterone, bodybuilders take testosterone for a reason. Why? It significantly improves muscle mass. It can decrease fat deposition. Many patients will report improvements in cognition. It can help with bone mineral density as well in men and women. And I also believe in depression. So I think testosterone does help with depression. I just want to make a very important point. Testosterone is not just about sex. There are 5 other things that you need to think about in men and women, and I want to talk about those. Men with low testosterone levels are much more likely to have a heart attack, non-negotiable. Men with low testosterone levels are much more likely to have diabetes, obesity. Men with low testosterone levels are much more likely to suffer from depression. Men with low testosterone levels are much more likely to have a bone fracture. So it's not just about sex, it's about their overall health. And if you were to check one blood test to assess a man's overall health, it's his testosterone level. One blood test to check his overall health. It would be because it affects heart, diabetes, obesity, bone mineral density, energy, muscle mass, erections, libido. One blood test. I can't think of another blood test that is a better barometer of overall health.